Greetings all. My name is Sonia and I'm from Empower School of Health. I welcome all the participants for today's webinar, and we will be starting the session in a couple of minutes now. I also would like to thank the moderator for today's session and both the speakers. Just give me a sec, please. For this session, we will be sharing the PPT, the certificate to all the participants. Also, the link will be shared with all. At the end of the session, we will be having a Q&A where you can put your questions on the chat box and those will be answered by the speaker. So as you can see on the screen, I would first of all request speakers to please check their mic if they can hear me or if I can hear them as well.
I'm hearing you good, Priya, but I hope you can hear me well.
Yes, Professor Andy, thank you. I would also request Mr. Felix also to please unmute himself, and Lucy also.
I'm able to hear you.
I can hear you just fine.
Thank you. Thank you for confirming. So as you can see on the screen, for today's session, we have a moderator, Miss Lucy. She is a B.Pharma Honors pharmacist at Galaxy Pharmaceuticals. For today's session, we have speakers, Mr. Felix. He is Associate Professor, Head of Pharmacy Department, Kumuzo University of Health Sciences, formerly College of Medicines, University of Malawi. And Professor Andy, he's the Director, Training and Capacity Building above Empower School of Health. And this webinar is, we are hosting this along with Pharmaceutical Society of Malawi. And for this session, the topic will be reverse logistics as a way of reducing expires in the supply chain. So now I will just give this platform to Miss Lucy to take it further. Thank you.
Thank you, Priya. Good day, everyone. I'd like to welcome you all to this webinar on reverse logistics as a way of reducing expiries in the supply chain. My name is Lucy Chimpukuso, and on behalf of Pharmaceutical Association of Malawi and the Empower School of Health, I'd like to welcome you all to this webinar. We will have two presentations from speakers who have had a wealth of experience in the field, one by Associate Professor Felix Kuluza, who is the head of the pharmacy department at Kamuzu University of Health Sciences, and lastly by Professor Andy, who is the Director in Training and Capacity Building at the Empower School of Health. Each presenter will be taking us on through the presentations, and we'll reserve the questions till the end of the second presentation. I'd like to now invite Associate Professor Kuluza to start us off. Over to you.
Thank you, Lucy. Thank you. Will I be sharing the screen or it will be shared from the?
Yeah, Mr.
Honors.
Felix, we will. I'll be sharing it over here. Let me just give the flow for the webinar. This will be the flow, the opening remarks. Then we will be having few slides about Empower and our partnership with PHASOM. Then a brief introduction of Mr. Felix that will be done by Ms. Lucy. The presentation of Mr. Felix. Then introduction of Professor Andy. And presentation of Professor Andy, and at the last we will be having a Q&A for 10 minutes and closing remarks, and there will be two polls also in which I would be needing the participation for all the participants. Now we will just move on to other slides, and I'll just quickly go through to the housekeeping announcement for participants. I would request to please mute your mic and turn off your cameras. Please ask your question during the Q&A session. As I mentioned to you all that we will be having a poll 1 and 2 where we need your participation. And as mentioned, the webinar recording, slide deck, and certificate for this webinar will be shared with all attendees. There will be on the next slide, this will be a housekeeping announcement for speakers and moderator. So please turn on your cameras for better engagement. Please mute your microphone when other speaker is speaking. Please adhere to the webinar schedule timing because since this is a 60-minute session. So the webinar objective for today's session will be the main reverse logistic as a way of reducing expiries in supply chain. So now this is the time to launch poll 1. I would request my backing team to please launch poll 1. And I would request all participants to please participate in this poll. These are the very generic questions which will give us an idea about yourself. So backing team, please launch poll 1. Preksha, I can't see poll. Hello?
Yes, yeah, we are doing that. Please give us a second.
Okay, so here we come, the polling. So there are a few questions. So you just need to select the respective answers, and at the last, we will just show the results to all. Attendees, please participate in this poll. This will be for a few minutes, and then we will stop it and launch the results. So they are very basic questions. What is your gender? What is your age? What is your geographical region? What is your academic background? About your profession and about your work experience. So very generic questions. And how did you hear about this webinar? So I can see the movement is there, 30%. So I would request all attendees to please participate. It will be live for a few seconds and then we will close and we will move on to the presentations. And those who are mentioning the certificates about the previous session, it's been already sent to all. However, if you haven't received it, please put it on the chat box with your email ID and your name, and we will send it to you again. Uh, 56% of participation. We will wait till 70% and then we will close it. I can see male audience is more than the female, and also the age group that we have maximum between 30 to 40. The maximum audience we have from Malawi, West Africa and Central Africa. No, the maximum is for elsewhere. That is 47%. The academic background maximum we have from pharmacy bachelor's degree. So now I would request backend team to please end the poll and show results to us. Yeah, so as explained to you, maximum is audience is a male, that is 62%, 38% female. The age, age of the audience is between 30 to 40. The geographical region is 47% from elsewhere and 19% from Malawi. Then the academic background, pharmacy bachelor's degree, that is 40%. I can see the working professional, there are maximum number of working professionals, that is 79%. And the year of experience, which is more than 5 years. And the maximum people who just knew about this webinar from Empower email and also PHASOM social media. Thank you for your participation. Now we will just move on to other slides. So I'll just give you a brief about Empower School of Health. As you can see on this slide, Empower is a capacity building organization and has worked over 100 countries across multiple languages to strengthen the institutional and HR capacity of global health through digital learning intervention. Our reach has already been reached out to 200,000 public health professionals. On the top, you can see 3 focus areas, that is leadership and change management, digital learning, public health, procurement, and supply chain. On the bottom, there are 5 domain areas, and for more information, you can visit our website that will be posted on the chat box. This slide will show you our reach in the Africa region as of now. These are all our collaboration, and Pharmaceutical Society of Malawi is one of our partners in Africa region, with whom we are organizing a few events for this year, and we have organized some events in the past. This slide will give you the idea about our advisors and faculty. Professor Paul Lalwani is a director Empower Group, former head of global funds, procurement and supply chain. And Professor Andy, he is one of the speakers for today's session. Now I will just give floor to Miss Lucy to introduce Mr. Felix, and then we will move forward to the Mr. Felix slides. Thank you.
Thank you, Priya. So our first speaker will be Associate Professor Kuluza. He's an experienced lecturer in management with a demonstrated history of working in the medical practice industry. He's skilled in clinical research, epidemiology, Microsoft Office research, and pharmacy. He has strong legal professional with a Master of Health Economics, focused in health economics from the University of Queensland, Australia. Over to you, Associate Professor Kuluza.
Thank you, Ms. Luce. I will take good morning, everybody. I think for others it's good afternoon. So I am Felix Kuluza, and I will take you through on the concepts of reverse logistics. Next slide. This will be the outline, which is we'll discuss on these issues. Next slide. Next one. Yep. No, the next slide. Yep. I will start with the news, which is very familiar in Malawi. Much of the news which you would find is there are always blame games on expired medicines, and they even attract international media. Like at one time, we were able to destroy 20,000 expired COVID vaccines. This was the time when COVID was really hitting us hard, both in Africa as well as international. But we were able to destroy those issues as well as a lot of expired medication. And if you look at the expired medication, you will see that one of it is like we may burn up to 2 billion kwacha, which is around $20 million worth of drugs. This is not a small amount for a country like Malawi, whereby the total annual budget may not be more than $30 million. So if within a period of 5 years, we are wasting almost the total annual budget going to waste because of expired medication, it's a worry. And we always say, well, why are we having this expired medication? What are the major problems? We have done something different to avoid these drugs from expiring or not. So that's where the concept of reverse logistics comes into play. Next slide. If you look at the factors which they would always contribute to the expire, you would find that sometimes there will be a push of near expired medication to healthcare institutions. And when those people they have received, they don't really think to say, can we share to other places or not? Can we move them up? Or maybe lack of clinical involvement, or the rapid changes in treatment regimens. Sometimes they would contribute to the expire. But when we are doing this, we could have maybe done something which could have averted those drugs from expiring. For example, HIV treatment, we always receive a lot of drugs for HIV. and people will know for sure when we'll change the treatment guidelines and thereof. But after some time, we'll still find that we are having those expires of HIV medication. And the question is, what do we have done to avert that from doing? Can reverse logistic really solve this or not? I believe that a reverse logistic could be one way of trying to minimize the expiry of medicines, which are always happening in our pharmaceutical supply chain system. Next slide. Some of the ways of preventing the expiry will be proper quantification and procurement, vetting of the nation, doing the first expiry, first out, conducting routine expiry data analysis. So, for example, if we are conducting much of the normal routine expiry data analysis, we'll be able to identify products which may expire on us even 2 years before they expire. And when we have identified those issues, what do? We just remain quiet. But there's need for a way for us to really say these products may expire on us maybe in 2 years' time. But we have the whole 1 year of thinking. What next? What do we do with that information? I believe that information we need to be able now to translate it and maybe do the reverse logistics from the primary health care up to the source of the medication, trying to make sure that these drugs are now being sent back to the suppliers. That's the way whereby I would see that the reverse logistics will be one way of trying to minimize this expiry of medicines. Next one. Yep, so next one. So when we say reverse logistics, what is reverse logistics? In a reverse logistics, we are looking at planning, implementation, and controlling the efficient, cost-effective flow of materials of pharmaceuticals and health commodities from the end user of a health organization to the manufacturers, or maybe to the upper levels of the supply chain system. Because pharmaceutical supply chain, we always think that the products should come from the suppliers up to the end user. But if the end user, who are the retail pharmacies, the customers, the health centers, they have more than enough because of a supply, what do we do with them? We need to have a concept whereby they should also think of trying to take back the excess stock and send them back to the what? To the suppliers in an efficient way, so that nothing is left to waste, because whatever we waste is money. Next one. So we should differentiate the reverse logistics from the moving of expired products or something maybe routine transfers. Because this one we are mainly focusing on things whereby they are unexpired, but they are overstocked items. So we need to be able to find a way of trying to reduce that and move them to the necessary upper steps, so that the upper steps, they can be able to redistribute them to other places where they can be consumed, rather than holding the stock and waiting for it to expire. In the end, we lose quite a lot of money within the health system, and that's not economical. Next. Why we need to do this reverse logistics, you find that sometimes, apart from the excess products which we have, but there can also be wrongly supplied products within the system. And without the proper way of moving the things upwards, this excess stock may end up going into the wrong hands. So we need somewhere, somehow, to be able to have a system which can take a product, whether it's public sector or private sector, from the primary health care, or where the products are, moving them up a little bit of a step, so that we are able to minimize the expiry of those products. As well as if it can also be done for maybe the complex of adverse drug reaction, maybe complex of substandard or unregistered, or they are failed, or maybe complex of obsolete things. Those things can also be part of reverse logistics, trying to move them from the primary care to the upper levels of supply chain, so that they can be properly handled. Next slide. So when we say reverse logistics, much of the purpose and scope would be to guide how we can return those medicines, excess medicines, from the downstream to the upstream. Because supply chain, we are just looking at the upstream to the downstream, but there's need for now to reverse that, whereby if there is more from the downstream, they should be able to also go to the upstream. And when we are doing the reverse logistic, it should be given the same importance as in any distribution of pharmaceuticals, because we are trying to minimize the expiries from the lower level, because any expiry is a loss of financial from the government, or if it's a private sector, it's a loss of a proper consumption from the system. Therefore, it's not economical, and that means economically we are losing more if we are not able to really do the reverse logistics of our medicines. Next slide. Next slide. If we have done, if we promote the reverse logistics in a proper manner, one, we would have minimal expiries and minimal wastage of medication, as well as the medicines will be properly stored. But at the same time, with a proper system, it means even diversions of medicines would be technically minimized. Because if there is no proper system of trying to get the products from the lower healthcare to the upstream, it means the process may be chaotic. And if the process is chaotic, there will be a lot of diversions, which may lead to drugs being found in registered places or in the wrong hands. So to minimize that, we need to have a proper way of how do we get those excess products from the lower level to the upper level for proper redistribution, or maybe even sending to other premises. Next slide. If you look at Malawi, initially our Malawi Health Commodity Logistics Management System, you'll find that that procedure was not there. So it was focusing on only getting the products from the upper level to the lower level. But currently they are reviewing it, and they have now realized that I think we need to have a system of reversing any excess supply from the primary health care or from where the products are to the upper levels. Because the drug can be in the system, but maybe people not accessing because it's at the lower end. But if there is a proper way of doing the reverse logistics, we believe that we may minimize those expiries. So it's one way of doing it. And usually we say, what about the private sector? Because the government now has realized that. But what about the private sector? Can't we have those issues in the private sector? Next slide. Yeah. If you look in the private sector, currently there is no major procedures, at least for the government like in Malawi, and majority of the government, I think they may have those things. If the government are not having it, I think I would say, let's introduce the reverse logistics so that we are able to save and minimize the expiry. If you look at the Malawian scenario, you'll find that the procedures for reverse logistics in the private sector is not there. But by law, somewhere in our act in the Malawi setting, you'll find that there's some sort of talking of the reverse logistics, not directly. If you look at the section, it's more focusing on, say, can we do a reverse logistics? Now, what it means is, as a private sector in Malawi, there's need for now to agree to say, do we need to have a proper also reverse logistics, whereby if the health suppliers, the retail pharmacies, the private clinics have excess stock, can they send back that stock to the suppliers? Because that's what it entails in reverse logistics. And if to the suppliers, can it be go back to the manufacturers? Because all these processes, we are ensuring that the products have reached to a proper place whereby they can be reused in other settings. That's the whole purpose of that. Can as a country have that in a private sector? Can any country in Africa have that reverse logistics? Majority of the countries in Africa, they purely are only downstream, but less upstream. So let's start now thinking of can we do the reverse logistics to minimize these expiries, which are happening in a lot of African countries, both in the public and private? Next slide. As part of discussion, that's the discussion point whereby we need to be thinking, do we need that in a private sector? The public, it's easier to say yes because of the system. What about the private? So this is a food for thought for all the people who are here to think whether we can do this or not. Thank you. Over to you, Lucy.
Thank you so much, Professor Kuluza, for the wonderful presentation. I believe that everyone here has more insight as to what it is, its importance, and why, and what steps and procedures should we take in both public and private sectors. To the audience, please be reminded that we will take all the questions at the end of the second presentation. Now, please allow me to invite Professor Andy. He's the Professor of Public Health and the Director of Capacity Development at the Empower School of Health. Andy is one of the co-authors of the Yellow Book, Managing Drug Supplies by MSH and WHO, and the Handbook of Health Systems in Action. He has over 30 years of experience of working with major international funding institutions, bilateral donors, and the private sector in low and middle income countries. He has undertaken donor-funded activities in over 40 countries, and we're very privileged to have him present to us today. Over to you, Dr. Andy.
Greetings and welcome to all. Okay, let's go to the next slide, please, because I have to speak rather fast to get through the material. Okay, reverse logistics as a way of reducing expiry, and the next slide, please. My message today is that because reverse logistics encompasses a whole range of activities, people often get confused and they focus on just one of the activities and say that's reverse logistics. It could be handling hazardous waste, that's reverse logistics. Or it could be accounting for vaccines, that's reverse logistics. In fact, reverse logistics is all of those and many more things. And by focusing on just one particular part of it, we get the wrong impression and we don't implement it and we don't use it. Recognize reverse logistics has many functions, but if it's going to work, if it's ever to be effective, we have to use an integrated system. Just doing one aspect of it on its own is not very beneficial. It has to be fully integrated. And in a few minutes, I'll explain what that means. Next slide, please. We've already had a definition of reverse logistics. Mine's exactly the same, so I think we can skip over that and move on. There are key differences for healthcare than other reverse logistic programs. You'll see lots of information around the internet all about reverse logistics. That is not particularly helpful to the healthcare scenario. First point that's different is no return from the consumer. If medicines or a health product has been issued, dispensed to a patient, we don't accept it back. It's no good saying it wasn't used, the patient died. No, we don't accept it back. That is, in many countries, a legal guideline. It's certainly an international regulation and guideline as well. The other point is we talk about return to the manufacturer, return to the supplier. In many cases, that's not practical either, because someone in the country will have to issue a certificate of pharmaceutical product, certifying that this medicine is still viable. Who in the country is going to do that? It's no longer the manufacturer has handed over responsibility for the medicine. Even if I'm trying to give it back to them, if I want to send a medicine or a health product internationally, I need a certificate of pharmaceutical product. Who is going to issue it? And often it's nobody. So doing international returns are exceedingly difficult, not impossible, but difficult. If it's an expired medicine, then I'm covered by the Basel Convention. I cannot send transboundary movements. I cannot send it internationally. The Basel Convention, and every one of your countries here today have all signed the Basel Convention, says that you will not export hazardous waste. So if it's not expired, it's difficult to send. If it is expired, it's impossible to send internationally. That's very different to other products. So healthcare reverse logistics is very different. Next slide, please. Well, why do we need reverse logistics? I mean, surely we don't have any excess medicine. We've never got enough medicine because everything is in flux. Everything is in change. Regimens, trains, we often have to estimate, a little more than guessing, how much each individual place needs. So although in total, we probably don't have enough medicine, in individual locations, it's easy to become overstocked. The main problem is that we don't have a standard operating procedure for undertaking reverse logistics. When we want to do it, everyone's trying to invent it and start from the beginning all over again. We need to have clear procedures in place to undertake reverse logistics. Otherwise, it just becomes highly confused. Next slide, please. So, reverse logistics, if you receive COVID vaccine, it was a condition of receiving the vaccine that you must have reverse logistics. But then everybody thinks, well, reverse logistics, it's only for vaccines. We don't do it for anything else. So the situation becomes confused by focusing only on one area. We need the same kind of procedures that we have for the vaccines across all health products for reverse logistics. Difficulty around the COVID vaccine was it was a specific one only for accountability. It wasn't trying to relocate stock to different places. It was trying to force accountability. That's one aspect of reverse logistics. But by focusing on that one aspect, we lose everything else that happens on reverse logistics, and we don't have the procedures for relocating stock. Next slide, please. So what is involved in this reverse logistics? Well, it could be as simple as packaging material. I send packaging material back to the center to be recycled. Can be waste materials. If I don't have the facilities available locally to handle hazardous waste, maybe I have to send that back as well. Can be goods, perfectly good goods, but I need to relocate them. I can't use them all, so I need to look at that. Lots of reasons for doing reverse logistics. Can be rejected, recalled medicines, recalled products, damaged goods. All of that goes into reverse logistics. And because there's so much involved, if we don't have standard operating procedures which are very clear, we don't get reverse logistics to work. Next slide, please. So why is it a problem then, this reverse logistics? We got normal logistics, we do that okay, because no one ever wants to be in charge. No one is in charge. And people rarely consider the cost. What's the cost in transportation, costs of sending this back? Is it really worth doing? If you've got 2 bottles of expired aspirin, is it worth sending it back? If you are overstocked on tetracycline by 2 or 3 months, is it actually worth sending it back? The transport costs can be more than the cost of the medicine or the health product. So we have to get used to having a procedure in place that puts people firmly in charge, assigns responsibilities, and helps us to assess the cost effectiveness of the operation. These are clear decisions that we need to make, but very few staff have ever been trained in reverse logistics. They don't have the knowledge and they don't have the experience in how to operate it. Next slide, please. So what does this mean? Well, first of all, there are regulations around medicines. If I'm going to send medicines back, someone has to inspect them and certify that they're still okay. If it's been in a rural clinic for 6 months, maybe there's no temperature control, is it still safe to reuse that medicine? Someone has to take that decision. And generally we call that decision maker a qualified person, a QP, and their role is defined in the WHO Good Manufacturing Practice for medicines and health products. Generally, anything from the market or dispensed to a patient has to be destroyed. Even though we might feel it's quite good medicine, the regulations are quite strict on that. Again, the problem comes, what experience do you have in managing returns? Who is an authorized person? Who can actually certify this medicine is still good for use? And what about the waste management? Who's had any training in waste management? Can I send the waste material in the same truck as the good medicine that I'm returning? Is that permitted? Again, we need clear standard operating procedures to tell us what's allowed. Next slide, please. So managing these returns requires a very clear policy. WHO has such policies. They're available, they're online, the links are on the screen. Some are for vaccines, some are product specific. Just for multi-dose vaccine vials, there's a separate clear policy. UNICEF has got a similar policy available. So there are product specific standard operating procedures, as well as general standard operating procedures for medicines and health products. Next slide, please. Here is an example of a standard operating procedure. This one is from Uganda. It's excellent. Everything is laid out exactly, step by step, what to do, who does what. And if you're going to have reverse logistics, that's exactly what you need in place. A clear standard operating procedure for operation at every level, from health facility, from hospital, to province or state store, to central medical store. Next slide, please. Well, what's all this got to do with expiry? Well, one of the first problems we have is identifying items that are going to expire, because often logistics people think in terms of number of boxes, but that's really not very helpful. What we have to do is convert our usable stock into months of usage. So easily we take the average monthly consumption, we just do a simple division. So on the screen there, usable stock in months, you can see 8 months stock at the top. Ritonavir, I've got 72 months of stock, but it's going to expire in 15 months. Very easy Excel sheet. Most of the logistics management information systems can do this kind of calculation if I set it up that way. So if I look at the stock in terms of months instead of number of boxes, then it's very clear. I can never use that amount of stock. I should transfer it to another place that can use it. That's the excess stock that I have. And simple calculations using months of stock instead of number of boxes enable us to compare the amount of usable stock in months with the time to expiry and then decide what's usable, what I need to transfer. Next slide, please. Well, does it really matter? It's a lot of trouble. All these standard operating procedures, all these forms and all this messing about. Is it really going to matter? Well, if we take an average typical expiry rate in public sector pharmaceutical distribution, it's around 3 to 5%. Using reverse logistics, it's relatively easy to reduce that by 1%. 1% of your total annual drug buy. For a medium population country, 20, 30 million people, that's around $3 million. Is $3 million worth doing? I think nearly every minister of health I've met would say yes. It's worthwhile putting the systems in place. Not only am I losing the value of the medicine, but it expires, I've now got to pay to destroy it. There's a cost to handling the waste medicine. So I've got a double whammy hitting me. So if I can avoid expiry and use reverse logistics, it can be very cost effective. Next slide, please. Reverse logistics is not easy. You do have to have these clear standard operating procedures. You do have to say who is going to be in charge throughout the process. But it can bring real benefits. If we look around at countries, very few countries have implemented it and got it in place well. It's long past time we did that. It's not that difficult to do. It requires simple standard operating procedures and to follow them. Let's try and do that. Okay, I hand you back now. I see I am a little bit over time, but hopefully there is time for Q&A.
Thank you so much. Thank you so much, Andy, for this wonderful presentation and introducing us to the different functions of reverse logistics and how to implement it from health facility to central medical store. Now it's time for questions. Feel free to raise your hand or type your question in the chat box.
Yeah, thank you, Lucy. Thank you, Professor Andy. Before going to Q&A session, there are a few slides which I need to take care of. This slide will give you the idea about our courses that we offer. We are providing this courses along with, since this is in collaboration with PHASOM. So we have special partial scholarship for today's attendees. So I'll just give you the brief about the courses that we offer. We have master's course that is for 24 and 12 months. We have postgraduate diploma that is for 12 months. And then diploma, and then we have many short courses, certificate courses. Those are from 2 months to 3 months, and most of our courses are available in English and French language. This slide, you can see a brief information about the fee for the course. For 24-month master's course, the fee is 8,000 USD. For 12 months, this is 5,500 USD. For PGD, postgraduate diploma, this is 2,500 USD, and these fees are exclusive of taxes and bank charges. For the request and interest for above courses, for anybody who's interested to apply for the partial scholarship or fee on concession on the fee, please contact us or PHASOM. So the process for applying for partial scholarship, you can simply reach out at our email ID that is mentioned on this slide. And please be sure that slide deck, recording, and certificate link will be provided to all. The link to download your certificate for today's webinar will be posted on the chat box. So you just need to fill up the form, and the certificate will be sent to your registered email ID. And also for applying for a partial scholarship, you can either get connected with us or PHASOM directly. Now this is the time to launch poll 2. This is the last and final poll. Please participate in this poll, and then we will move on to the Q&A session. Thank you. We have over 250 attendees for today's session, so I would request all to please participate in this poll. It will basically help us to organize future upcoming webinars, and with your feedback only, we will be able to improvise ourselves, So the first question is, was this information useful for you? So I can see 100% is towards yes. Would you like to receive more information on any of the topic? So I can see people are more interested on reverse logistic and supply chain. Okay, are you interested in working in supply chain? That is 90% as of now. Are you interested in enrolling in supply chain courses? So the interest is 89%. So for any for any information related to our courses, as you can see on the previous slide, we have many short and long term courses in supply chain, so you can get connected with us. For more information, you can visit Empower School of Health website and educational website. The link is posted on the chat box. So I can see 53% of attendees had participated in this poll. I would request others to please participate also, and then we will close this poll. Thank you all. You just don't need to do much for a participate in this poll. You just need to select the respective answers and submit your poll. So 63% of the attendees have participated as of now. Now I would request my backend team to please stop the poll, and then we will move on to Q&A session. So you can see the results. I have already given you a brief information about it. So thank you so much. Now we will be moving forward for the Q&A session. Thank you all. Lucy, over to you.
All right, thank you. We have a hand up, Amos Lucky Mohone.
All right. Hi, can you hear me?
Yes, we can.
All right. Thank you so much. Thank you, Prof. Andy and Dr. Felix, for wonderful presentations. I just have a few questions that I want to ask. They are all related. My name is Amos Mohone. I'm coming from a veterinary background, so I'm more into veterinary medicines. So the first question is, implementing reverse logistics in a public health setting, I believe it's much straightforward because part of our public health is free, the hospital setting is easier, but can we implement it in a veterinary setting where much of the profession is privatized? Because even if I work for the government, I charge for every service I do personally, and it's more privatized. So can we implement reverse logistics in a veterinary setting? That is number one. Number two, in a private setup, for example, I have my own pharmacist and my own pharmacy in a private setting. How do we balance the two, reverse logistics and business? Because each time a product is coming out of my hands, either going to the wholesaler, going up the chain, there has to be money involved. How do I balance the two? And then lastly, it's about antimicrobial resistance. Can reverse logistics be a solution or one of the solutions to antimicrobial resistance, particularly antimicrobial usage? Thank you.
Right, that's a lot to answer at one time. I'll try and be quick, and then perhaps Dr. Felix will add to what I have to say as well. Can it be used for veterinary medicines? Yes, certainly. Can it be used in the private sector? Yes, but in the private sector, again, you need clear standard operating procedures, which are usually contractual agreements with your distributor and suppliers, because you're changing ownership. As you change ownership, there is a financial liability as well. So you need a contractual relationship to bring you the procedure and the change of ownership and payment. But yes, it can operate. It operates very well in some countries. Most of Europe has reverse logistics with pharmaceutical distributors in the veterinary and in the retail sector as well. Perhaps Dr. Felix would like to add to anything on that.
Well answered, Prof. I think what I may add is, can it be used maybe in the antimicrobial stewardship or resistance? I believe yes. What I'm saying is sometimes you would find that public facilities would receive donations directly at the rural health center, whereby they don't have the capacity, and the antibiotics may be there in the reserve category. So in that perspective, I think we can use it to get away from those reserve antibiotics or watch antibiotics to the upper levels, because of the necessity of the capacity of the people who are in the primary health care. That's what is I may add on to that. Thank you.
Thank you. Thank you.
Thank you. We have another question from Sakrani.
Hi. I have a question. The first one, I think I sent it to the chat, and it's on, do we have guidelines for determining the indirect costs attached to reverse logistics for medicines? Because the public sector in most developing countries is resource constrained. So this reverse logistics management may demand, I should say, does demand human capital and distribution vehicles, which may further strain an already fragile system. And the other thing is on quite like an observation or a comment. In the public sector, especially in Malawi, at the service delivery point, we may face resistance in reverse logistics because of product availability uncertainty. I'll give an example in the wards. Nurses may refuse to return medicines to pharmacies because of fear of stockouts. So I feel like for us to implement reverse logistics, there has to be some increase in product availability. People have people who deliver service at the end point have to trust our system that they may be replenished, especially for products that are near the expiry. So that was the first question. Thank you. That's all.
Right. Felix, do you want to start? Okay, are there guidelines for costings? Yes, there are guidelines for costings on reverse logistics. Okay, then over to Felix on the other questions, perhaps.
Can this happen in a setting whereby it's a public sector? Yes, it can happen. We know for sure that every person will have the thinking to say, since we have a lot of expiries, then let's hold it. But if you have a proper policy and then there's more improvement, I think it can happen, because we are not saying that the reverse is just to get away from the facility, but sometimes it's to make sure that it's well distributed. If you remember, I may give maybe one example of last year or the other year, whereby we had shortages of one of the anesthetic drug, only to realize that one hospital had more than enough of the same anesthetic drug, while the rest of the hospitals in the government sector did not have. So that's where we are saying, yes, we need to, that mentality of saying things may be out of stock, it needs now to start now going into even those cadres, the nurses, the medical doctors should be able to accept the reality that we are not taking out from that, but we are trying to redistribute, whereby centrally people will see the system and see where there is shortages and move that to those areas for the benefit of the whole country. Otherwise, a lot of drugs will just be expiring on us. Thank you.
Thank you. We have two more questions from Stanley Meke and Richard Makala.
Okay. My question goes to Professor Cruiser. In Malawi, is there any political will for this reverse logistics? Because most of the medication that get expired, they are donations. And we can understand that these donations, they come from upper levels into facilities, knowing the consumptions of those facilities. The other point is on the cost. If the cost can be there for the primary health care to send those meds back to the upper levels, I think it's either in public sector for that reverse logistic to happen. But my question will be, on the health centers, will there be anyone who will be responsible for these reverse logistics? Thank you.
Thank you very much, Stanley. I think in Malawi, the first question is there political will? I would say currently now there is more political will because the system for health supply in the public sector was being revised, and reverse logistics has been included with all the procedures and the roles of each individual from the health center level up to the central level. On the issue of pushing of donations, I would say the donations, yes. I would say on the donation, yes, there is a political will, in the sense that within that we have also tried to tackle what are the powers, how to receive and thereof within the same documentation, as well as the current Pharmacy Act. We are reviewing the regulations, and in the regulations, we are clearly now having regulations for donations. The main aim is to minimize those pushing of donations to the primary health care. And in terms of costing, the manual which is being developed has made sure who is supposed to have the powers, the logistics of the transportation system and thereof is within the same manual, and how to organize that, at what interval can they do that. So the manual has tried to clarify all the steps. So the political will is now there. The moment everything is approved, I believe that it will be there. Thank you.
Thank you. We'll have one last question from Richard Makala. Richard Makala.
Hello. Hello, Luz. Can you hear me?
Yes, we can hear you.
Yes, my question was, is there any global guideline on the rate of expiries among the different levels of the supply chain? For example, at the national level, at the health center level, as to the kind of transactions or kind of commodities they handle in terms of quantities and values. How much is an acceptable level of expiry? Is there any research done, maybe, or experience from other countries?
Okay, I'll take that in two parts. How much is acceptable is the decision of your minister.
Yes.
A typical level is shown on the slides. I give you a quote there from Managing Drug Supply of 3 to 5% of the value of the supply chain is present. That's a typical level. You will always have some expiry. There are some products that you want to expire. You keep anti-snake venom. You don't want to have to use it, but when you need it, it's got to be there. Anti-snake venom has a short expiry date. So quite often, anti-snake venom is going to expire. But do you really want to tell a parent their child has died because you were afraid of the expiry and you didn't have any in stock? So some items will always expire. That's natural. A acceptable level is a political decision. A typical level is 3 to 5%. That can be reduced down to 1% with relatively simple, easy procedures and still keeping emergency supplies in stock. And you'll find the figure quoted on the slide from Managing Drug Supply, so you have got a published source to quote the figure. Okay, I see we're on time, so back to you, Lucy.
All right. Yeah. So that will be the end of our Q&A session. Over to you, Priya.
Thank you, Lucy, and thank you, Professor Andy and Mr. Felix, for the Q&A session. and for the answers. I hope these will be, favorable and benefited for the audience. So now we will be posting the certificate link to download your certificate, and the certificate will be sent to your registered email ID that you have used in the Zoom credentials. And also at the end, I would request all attendees, speakers, and Lucy to turn on your camera. So we'll take a final snapshot of it for the social media uh, thing. So I would request all, and the link has already been posted on the chat box. So I would request all to fill up your form, and the certificate will be sent to you. And the slide deck recording will also be shared with all the attendees post webinar. So I think there is a security reason. Okay, so now I have allowed all attendees so they can turn on their cameras. And social media team, please take a snapshot of it, and then we will close the session. And thank you all for your presence.
Requesting everyone kindly turn on your camera so that we can take the screenshot.
And for more upcoming session, please visit our social media page. The link is posted on the chat box, so you will be notified for all the upcoming session and the topics. Thank you all for your attendance. I think we have already taken the snapshot, and it's time to close the session. Thank you, speakers. Thank you, moderator. And thank you, PHASOM, for your support. Bye-bye. Take care.